Welcome everybody to this afternoon's webinar. Everyone is just joining at the moment. We're expecting around 300 participants, so it's going to take a little while for them to come in, but I'd just like to say welcome, and my name's Sue Thomas and I'm going to be chairing this afternoon's meeting. We're going to talk about gastric issues in Parkinson's disease, and I think this is extremely topical at the moment, and given the number of people that are joining, we can see how popular it is. We've got a really great lineup of speakers, and I'd like to thank our sponsors, Kiowa Kirin, for sponsoring the meeting today. They've had no control at all over the educational content in this activity. So in terms of our speakers, we're going to start with Dr. Fiona Linthander, who is going to give us an overview of the GI system and dysfunction, and then pass over to Michael O'Brasel, who will talk about the interplay between Parkinson's comorbidities and nutritional status. Rochelle Flanagan, who's also a dietitian and Parkinson's advocate, is also going to review Parkinson's and the effects of nutrition. And Lynn Osborne, who's Parkinson's disease nurse consultant in Cornwall, will finally present a case study for us to review. So I think we're in for a really great hour's lecture around the gastric issues in Parkinson's. So I'm going to ask our first speaker, Dr. Fiona Linthander, to kick us off this afternoon. It's very timely because Michael and Fiona have just published their paper around Parkinson's and nutrition. So over to you, Fiona. We're delighted to welcome you this afternoon and really look forward to hearing what you've got to say to us.
Wonderful. Thank you very much, Sue, and thank you to the Neurology Academy for the invitation to speak today. So it comes as no surprise to this audience, I'm sure, that the global prevalence of Parkinson's will increase as the population ages, and it's therefore really important that we try to understand the interplay between Parkinson's comorbidities and nutritional status. So I'm a dietitian, I'm a nutrition scientist, and I collaborate with colleagues in the Aging and Movement Research Group at the University of Bristol. This group is led by Dr. Emily Henderson, and we conduct a range of studies and trials in Parkinson's. And in many of these studies and trials, we investigate nutritional status or components thereof. And as a result, we were recently invited by the Nutrition Society to write a review article, seen in the next slide, to really examine the literature in the area of nutrition and Parkinson's. This review was just published last month and was picked up far and wide. So I'll move on to the next slide, please, just to highlight that there are many nutrition-related issues that people with Parkinson's face, as you can see on this slide. And these include cognitive effects, tremor and dyskinesia, issues with muscle health, bone health, worsening dexterity. So really over the next 10 minutes, what I'd like to cover is gastrointestinal dysfunction that can be seen in people with Parkinson's, as highlighted here in blue. And then I'm going to hand over to my colleague, Dr. Michael O'Brasel. Michael was the lead author on the review that I've just mentioned, and Michael will talk through the interplay between Parkinson's comorbidities and nutritional status. So I'm going to first talk about enosmia, so absence of smell, and that's frequently reported in people with Parkinson's. It often occurs many years before the onset of motor symptoms, and it can affect up to 90% of people. Dysgeusia, less commonly reported, but taste is heavily dependent on the sense of smell, and the two interlinked can affect up to 27% of people with Parkinson's. The evidence suggests that these two factors alone can adversely affect dietary intake. And in a case control study, Aidan and colleagues assessed dietary intake using two very nice methods of assessment, 3-day food record and 24-hour recall. And they found an association between lower intake of nutrients such as protein, polyunsaturated fat, and olfactory function. And that was in a group of people with Parkinson's who were just newly diagnosed. Do these factors impact on weight and hence nutritional status? The answer is yes. And studies have examined the relationship between these symptoms and body weight and have found that deficits in these areas can negatively impact body weight. So moving on to dysphagia, so that's commonly reported in Parkinson's, and a meta-analysis carried out by Kalf and colleagues in 2012 showed an estimated symptomatic prevalence of about 35%. However, when you use objective measures of measuring swallowing function, the prevalence is further increased up to 82%. And that suggests that asymptomatic dysphagia is widespread and may occur silently. Swallowing issues, importantly, can negatively affect quality of life, and that may be directly through perhaps embarrassment in social situations, fear of choking episodes, as well as the impact that dysphagia can have on dietary intake. And the presence of dysphagia, of course, is a risk factor for adverse outcomes such as pneumonia through silent aspiration. As xerostomia and conversely hypersalivation, they can be linked or affected by some of the medications that people with Parkinson's take, such as levodopa and other factors that may impair swallowing. Xerostomia, of course, can be linked with taste abnormalities. A dentition, I haven't noted on the slide, but that can be an issue whereby people with Parkinson's have worse dentition than similarly aged individuals, further impairing ability to eat. Orofacial issues and orofacial pain, such as burning mouth syndrome, is an increased prevalence in Parkinson's, and that can cause potential distress when eating. So each of these factors on this slide, either alone or collectively, can impair dietary intake and can have a negative impact on nutritional status. And moreover, difficulties in ingesting food may impair the intake of specific nutrients such as vitamin D and calcium, subsequently increasing the risk of fracture. And that will be discussed in more detail in the next presentation by Mihal. And moving on to the next slide, please, we're going to have a look at the stomach. So delayed gastric emptying is a common issue due to poor motility, and that can result in nausea, bloating, early satiety, and all of those factors can adversely affect appetite and in turn dietary intake, and of course increase the risk of malnutrition. And motility issues can also affect dopaminergic medication absorption and hence worsen motor control. The relationship between gastric emptying and quality of life has been investigated, and many people have reported a poorer quality of life at those individuals who have issues with gastric emptying. We'll move on to the next slide to look at changes in the gut microbiome. So this slide shows data from a systematic review published earlier this year by Lee and colleagues, and looking at small bowel gastrointestinal overgrowth, something that's been commonly observed in Parkinson's. So the data presented here by Lee and colleagues showed that it affects an estimated 46% of people with Parkinson's and is characterized by an overgrowth of bacterial colonies beyond normally observed limits or the growth of abnormal types of bacteria. And diagnosis relies on the use of hydrogen breath tests to infer growth. That was used in many of the prevalence studies listed here, although the gold standard is the physical culture of jejunal aspirate. So this gut microbiome is well documented to be abnormal relative to healthy controls, and an overabundance of particular species are associated with the risk of GI symptoms such as constipation, which I'll get onto in a couple of moments. And a number of hypotheses have been proposed around the effect that these bacteria in the gut may have on nutritional status. So these include a decreased absorption of vitamin D, which of course may increase the risk of fractures, which again Mihal will speak about in a few moments, and also a degradation in bile acid, leading to a decrease in the absorption of dietary fat and some fat-soluble vitamins. So moving on to the next slide, we're going to have a look at constipation, which is the most commonly recognized GI symptom in Parkinson's. And that refers both to a difficulty defecating and a decreased frequency of stool, and has been reported to affect 20 to 80% of people with Parkinson's. It can be observed as a prodromal symptom predating the onset of defining motor symptoms. In fact, anosmia has also been reported as a prodromal symptom predating those motor symptoms. And constipation is linked to worse outcomes that include earlier onset of dementia. And symptoms arise from the degradation of brain structures involved in controlling storage and expulsion, as well as the nerves of the mesenteric plexus within the bowel that control motility. And there's no doubt, it's been reported widely that constipation is a risk factor from malnutrition. So I just want to go through 2 or 3 studies which have looked at the relationship between nutritional status and constipation. So in a sample of community dwelling patients with Parkinson's, nutritional status was measured using 2 validated tools of nutritional status. One is called the Subjective Global Assessment, and the other one is called the Patient-Generated Subjective Global Assessments, 2 widely used tools. And 43% of the cohort in that study reported previous unintentional weight loss following diagnosis. 15% were moderately malnourished, wherein constipation was one of the symptoms reported to adversely affect dietary intake. Another study I want to highlight where, again, one of these tools of measurement of nutritional status was used, the patient-generated subjective global assessment. And this was in patients awaiting a deep brain stimulation surgery. And of the nutrition impact symptoms listed, 58% recorded, 58% of the cohort reported that constipation adversely affected their dietary intake over the previous 2-week period. And finally, in a cross-sectional study of people with Parkinson's in China, constipation was considered to be one of the 2 most important predictors of nutritional impairment. So to conclude, there's no doubt that gastrointestinal dysfunction is common with people with Parkinson's, and many factors can negatively impact nutritional status. Further research may contribute to the development of interventional strategies to improve symptoms, to augment care, and to importantly enhance quality of life for patients living with this complex neurodegenerative disease. Thank you.
Thank you very much, Fiona. That was really interesting. A great start. We'll pass straight over on to Michal to look at the interplay between Parkinson's comorbidities and nutritional status now. But I'm sure if there are questions, people can start to add those to the Q&A box, and we'll come on to those later. Michal, are you ready to speak to us?
Absolutely. Thank you very much. And thank you, Fiona, for setting the scene for this. So I'm going to talk about the interplay between Parkinson's comorbidities and nutritional status. And I'm going to talk about 3 specific comorbidities which nutrition can have quite a bearing on. This is a figure from our paper. The issues that Fiona has just touched upon are highlighted in blue. These are the GI symptoms of Parkinson's. And as you can see from this plot, we move from the prodromal stage of the disease all the way across to an increasing burden of neurodegeneration. This figure also highlights 3 aspects: weight, which is quite intrinsically linked to malnutrition, people's bone mass. As you know, as Fiona alluded to, that the incidence and prevalence of osteoporosis are quite high in people with Parkinson's, and also muscle mass, which people with Parkinson's are more predisposed to sarcopenia. One of the key things I'm going to focus on is that although we have quite smooth lines on this diagram, in fact, when you dive down into the data, you find that it's quite heterogeneous, and there really is a need for greater research in these domains. So many of the gastrointestinal issues that Fiona has just touched upon can actually factor into malnutrition in people with Parkinson's. And when we were writing our review, we went through quite a bit of malnutrition literature, and we were slightly surprised to see that the most recent systematic review in this area by Sheard and colleagues, it's a very good review. However, it was conducted in 2011, so over 10 years ago, and there hasn't been a more up-to-date version published. It's a useful review because they pooled that data from over 1,100 patients living with Parkinson's across a variety of countries. 4 of those were in the UK, 3 were in the US, 2 were in Italy, and both were in China and Australia. And one of the key things that you see from the tables in this is the absolute heterogeneity of definitions of malnutrition used. So that from 7 different studies, they estimated that the prevalence of malnutrition in patients with Parkinson's ranges from 0 to 24%. However, many of those studies have quite different methodologies and use rather different cutoffs. In some cases, simply BMI under a certain threshold is applied. Similarly, not all of these studies looked at the risk of malnutrition, although 4 of them did. And again, there's quite a wide range in this of 3 to 60%. And again, this was the result of different definitions being used in rather different populations. So in terms of the importance of malnutrition and monitoring malnutrition in patients with Parkinson's, there was some really good guidance issued this year in the form of the BDA and PDUK guidelines for dietitians treating those with Parkinson's. And this quote really stuck out to us, highlighting the importance of continuously monitoring both the risk of malnutrition and body weight across the spectrum of disease, starting with people when they're diagnosed and moving all the way as their condition progresses. And the importance of this in terms of people's motor symptoms, worsening dyskinesias, and the importance of preventing reversible weight loss in people who are living with Parkinson's. Moving to muscle health, malnutrition is actually one of the leading risk factors for sarcopenia. However, it's a little bit uncertain at present what the actual prevalence of sarcopenia is in patients with Parkinson's. This is despite a flurry of recent papers in the area. The ESPEN neurological guidelines, which are quite comprehensive, covering a number of different neurodegenerative diseases, were published in 2018. However, they suggest that the prevalence of sarcopenia in people with Parkinson's is uncommon. And they cite a single paper from a very good Italian group, which found in a population of people with atypical and idiopathic Parkinson's that the prevalence of sarcopenia was 7%. However, recent studies are actually suggesting that the prevalence may be somewhat greater. This stems in part to very different clinical definitions being applied, which makes it incredibly difficult to compare studies to each other or even to compare populations in different parts of the world. And I hope that this slide helps summarize some of that heterogeneity in the terms in the definitions that are being used by different groups. The Vetrano paper from Italy in 2018 is very interesting because it shows with 3 sets of commonly used guidelines how the prevalence of sarcopenia in people with Parkinson's can differ. In contrast, you can see that most other studies have either used a single definition or have used older versions and newer versions of the same family of definitions. One example being the Daluz paper from 2021 in Brazil. Sarcopenia is also somewhat intertwined with bone health. If people have weaker muscles, they may also have weaker bones and be more prone to falls, increasing their risk of fracture. As Fiona touched upon in the first set of slides, vitamin D deficiency seems to be quite common in Parkinson's. And case control studies at least suggest that people with Parkinson's have lower serum vitamin D levels. However, again, there is significant heterogeneity in the literature, something we keep coming back to. However, in the case of bone health in Parkinson's, it is somewhat more complex. Due to a series of fraudulent papers, which are now retracted, the picture remains somewhat unclear, as these have stayed in meta-analysis published before the time of retraction, which are still widely cited. We found this somewhat problematic when we were actually working on our own review, trying to keep track of which papers had been retracted and which systematic reviews and meta-analyses might have been tainted somewhat by those publications. What does appear clear, however, is that people living with Parkinson's are at risk of having lower bone mineral density than controls. And there does appear to be an increased risk of fracture in people with Parkinson's, particularly at the hip. The 3 references, Kumar et al. 2017, Chen et al. 2012, and Mullenfeld 2021, are quite useful examples of this. This is a really, really nice systematic review and meta-analysis by Sheeny et al. Published in the journal Bone in 2020. This was looking at fractures in people with Parkinson's across, if memory serves me right, 15 cohorts and 3 case control studies. And what they found is that the evidence for hip fractures, the increased risk of hip fractures in patients with Parkinson's, is far greater at the hip. However, the data are quite heterogeneous, in contrast with non-vertebral fractures, where there's lower heterogeneity in the data, but the effect size is less. So hopefully that has been a bit of a whistle-stop tour about 3 somewhat related comorbidities, which are heavily influenced by nutrition status in people with Parkinson's. I think the major message from all 3 of them is more research is required in this area, both in terms of synthesizing the data that have been published in the literature, but also in terms of new research to help establish greater certainty around the prevalence of these comorbidities in people with Parkinson's. And then just to acknowledge members of the Aging and Movement Research Group, Dr. Emily Henderson and Professor Yoel Ben-Shlomo, in addition to our co-authors, Dr. Emma Tennyson and Dr. Matthew Smith, who were involved in the write-up of the review.
Thank you so much, Mihal. That's been a fascinating introduction to the topic. So really good. And if anybody wants to read more in depth about this, there is the article that's just been published, Parkinson's Nutritional Perspective, and we can put a link of that up at the end so that people can see where to access it. But I think that was a great start for us there. We're now going to pass on to Rochelle Flanagan, who is also a dietitian. We've got an abundance of dietitians here this afternoon, and I see in one of the questions it says not everybody's got access to a dietitian. How can we ensure appropriate management of patients? So that's something that I'll come on and ask the panel about afterwards, how we get around that. But Rochelle, over to you now, please, for your presentation.
So thanks very much. I'm delighted to be on air with my colleagues, my dietitian colleagues who are doing great research in Parkinson's, first of all. So there might be a little bit of overlap, but I suppose I'm coming to this topic from two hats on. One is as a registered dietitian for the past close to 18 years, and the second is as someone who was diagnosed with young onset Parkinson's disease, myself 5 years ago at the age of 47. So I kind of coming from both angles. So now just get my slide to move. Sorry, just bear with me a second. Okay, so basically just the agenda in terms of my presentations. I'm going to just present some results from a Parkinson's Association of Ireland survey we did of our Dublin members. I'm on the Dublin committee here in Ireland. I'm going to talk about who gastrodysfunction affects, what affects gastrodysfunction, and how to improve gastrodysfunction. So first of all, in terms of the Parkinson's survey, we did it about 80 people, Dublin members responded to the survey, and on average, sort of 80% were over the age of 65 and had Parkinson's for approximately, I think it was about 8 years. So just, I suppose, really to back up what is, the research literature, this is just a survey we did of our members. But basically it showed that only 4 out of 10 of the people with Parkinson's were weighed by their GP or neurologist. 60% of the respondents had actually lost weight unintentionally. So just kind of coming on the back of the presentations by my colleagues in terms of malnutrition and weight loss, et cetera, being an issue. Obviously, one of the problems we have is people in reality in clinics are not weighing people with Parkinson's. That's really important. In terms of gastrodysfunction, 25% experience problems with choking or coughing when swallowing food, because the gastric system is not just about the stomach and the intestines, but it is from the mouth, to the gullet all the way down. Also, the most common bowel problems were constipation, wind, and/or incomplete bowel movements, and 6 out of 10 had constipation. So again, just backing up the research literature in terms of how prevalent these problems are. So I suppose the other thing is often we think of, the Parkinson's population as being just about older people with Parkinson's, especially in terms of gastrodysfunction. But recently I came across this paper, which is looking at an Asian population, and it showed here the top 3 symptoms of most commonly concern to different people across the Hun and Yar staging. And you'll see here from stage 1 right through to stage 5, constipation is prevalent. So obviously stage 1, it's low, it's only about 17%. It creeps up to 36% in stage 2, almost 50% in stage 3. Stage 4, it's around 40%, and then in stage 5, it's about 40% as well. So really, constipation is a problem from the get-go. Then they actually, so basically overall constipation is related as the most commonly concerning non-motor symptom. And then what was most concerning is, again, in terms of the difference between young onset and typical onset, which would be later onset, what was the comparison of the most concerning symptoms? So you'll see here, For the young onset, 48% were concerned about constipation, which is higher than your typical onset. It was only 39%. And when it came to adverse events around gastrointestinal symptoms, it was higher again in the young onset versus the later onset, typical onset. So again, constipation was rated as the most commonly concerning non-motor symptom by both patient cohorts, but very strongly in this paper shows that young onset people actually reported it more regularly and had more adverse events. I think this is apparently the only paper that's kind of shown it in this sort of way. And there's very little research about young onset Parkinson's. And just to flag that with young onset Parkinson's, I was just doing some research in this. So there's approximately 10 million people worldwide suffering from Parkinson's. Of that, they estimate up to 20% are early onset, which is under the age of 50 or 60, depending. They haven't quite clarified the cutoffs in terms of young onset and early onset. But that would, that would give you that 2 million people around the world suffer from early onset Parkinson's. So it's an area that's really underrepresented in terms of research and in terms of the impacts of the various different symptoms. And in this particular case, I think it's very strongly showing that we are underserving our young people with Parkinson's around gastro issues. So the what then? So basically in terms of, it's kind of a vicious circle as far as I'm concerned. And many people with Parkinson's are concerned, and as a dietitian, trying to help people with Parkinson's. So basically Parkinson's itself can cause constipation, but constipation is also a prodromal symptom of Parkinson's. Levodopa can improve constipation, but levodopa can worsen constipation. Pain is associated with worsening constipation, but pain medication can worsen constipation. Pain can reduce one's ability to exercise, but less exercise has been shown to worsen constipation. Delayed gastric emptying worsens constipation. And then obviously on top of that, we have other things that have been alluded to, which is H. pylori and SIBO can obviously worsen general gastrointestinal symptoms, bloating, wind, pain, all those kind of symptoms. And obviously we need to take into account there's many comorbidities that people with Parkinson's can also have that affect the gastrointestinal system. And that is things like celiac disease, of which I have myself, and I know many people with Parkinson's do. IBS, people with Parkinson's have a higher prevalence, have quite a high prevalence of IBS, which is irritable bowel syndrome. And as we know, inflammatory bowel disease is also often a comorbidity with Parkinson's disease. It's actually found that people who are on anti-inflammatories reduce the risk of developing Parkinson's, but there are still people I know out there who have both conditions. So I suppose really what I'm saying here is that it is a kind of vicious circle, and really as clinicians and researchers, we really need to look, be a detective and look at, a person individually and see what exactly is going on for them and how their sex, how their ethnicity, how their age all impacts, and how the comorbidities impact their gastrointestinal dysfunction. The other thing I just wanted to show here in terms of this slide, I think was really powerful for me as someone living with Parkinson's, but also as a dietitian, is that this is the variability of levodopa that's seen after someone ingested a single levodopa tablet. So you can see this huge variability. So that has to be taken into account in terms of, what's going on for the individual person with Parkinson's, and where maybe the dysfunction of that fluctuation of variability of levodopa absorption has been affected by the gastrointestinal system. So I suppose in terms of then how to improve, gastro dysfunction, obviously one of the main things we deal with anyone who has, as a dietitian, has any sort of, constipation, or we would look at their fiber intake. And we know through research that people with Parkinson's do not take enough fiber in their diet. So they should be getting between 25 and 30 grams of fiber a day. It should be a mix of soluble and insoluble fiber. So soluble fiber is things like your fruits and veg and your pulses. They help to kind of give a gel consistency to the stool to move it through the bowel. And then insoluble fiber is your whole grains. It's like nature's natural broom. It's like the whole grain rice, whole grain pasta, whole grain breads, different types of grains, quinoa, buckwheat, those kind of grains to help move the bowel, the stool through the bowel. And then fluid. So there is research to show that people with Parkinson's do not take enough fluid on a daily basis. So this is really important, A, to get the tablet from the mouth down into the stomach, and B, to ensure that they are not dehydrated, which obviously can worsen your constipation. The other thing then is, in terms of laxatives, sometimes people are sort of concerned, should I use a laxative, should I not? The reality is with Parkinson's, we have a slow bowel because of the Parkinson's itself. So I think we shouldn't have a fear about using laxatives. Obviously, we want to use first line, which is, fiber, water, etc. But in terms of laxatives, we need to look at considering them. So there was a study done in King's College London, which actually looked at rigidity as in terms of Parkinson's disease relative to laxative treatment. And it was actually shown that laxatives actually helped to improve the symptom of rigidity. I've actually gone and taken part in a study under this team, under Sylvia Dobbs, and I'm really excited to see the rest of their study results. But it's very strong indication that laxatives, and they felt that it wasn't just because it might improve constipation, but actually it might improve dysbiosis, which has been associated with worsening of Parkinson's symptoms. So as Sylvia Dobbs says, like on the paper said, like in other chronic diseases, Parkinson's is likely to be multi-step, multifactorial, but this does not preclude a systematic explanation and interim clinical solutions. Targeting environmental influence has potential for cost-effective screening, prophylaxis and amelioration. So in other words, like we should be getting in early with these things that we can treat at the gut level through the likes of laxatives. And the other thing I want to bring in here is swallow function. We often think of just gastro as the stomach and the intestines, but actually, as I say, our swallow is part of our gastrointestinal function. So, and I wanted to put this in because I really truly believe we are underserving the Parkinson community by not assessing swallow from the beginning, whether you are a young onset or early onset or late onset. We should be assessing this because dysphagia can happen in 58 to 80% of dysphagia in the early stages and 95% in late. Pharyngeal esophageal dysfunction appears before the clinical manifestation of dysphagia happens. So a bit like constipation, a lot of people with Parkinson's report that they're not constipated, but when you actually objectively look at it, they actually is a much higher presentation. Similarly, with swallow, when people are asked, the patients are asked whether they have swallow issues, 35% reported, but actually 82% were actually shown to have problems with their swallow when the clinician assessed them. So 4 out of 5 people don't realize they have a swallow problem. So the reason I mention this is that, if the tablet, the levodopa, is not even getting past the back of their throat and down in to the stomach, well, they're at a deficit to start with in terms of improving their gastrointestinal function. So this is quite an interesting paper that was just published in 2020, and it showed that the things that negatively impact GI dysfunction were obviously length of duration of Parkinson's, but I think the paper I showed you, which was looking at earlier on at the young onset, shows that actually it's just because studies are not taking into account the young onset. Motor fluctuations can obviously negatively impact it, and chronic pain they found is a direct impact on GI dysfunction. Lack of physical activity was a big factor in terms of GI dysfunction. So they found that people with Parkinson's in this paper who were on average, much less active and sitting an awful lot more, and it was directly related to GI dysfunction. Female gender was actually associated with GI dysfunction. And it's just on that point, we need to take into account women's menstrual cycles, because we do know that the menstrual cycle impacts GI dysfunction. So we need to take these things into account when we're looking at the individual. So this paper would say to treat GI dysfunction, we need to proactively treat constipation and upper GI symptoms. We need to encourage physical exercise. We need to treat chronic pain, because pain itself can make GI symptoms feel worse. And also to rationalize the Parkinson therapies to make sure, because there's things like some of the agonists have been associated with potentially increasing dysfunction, and also the intestinal gel has been associated with, in this paper, with upper GI symptoms like bloating and wind and reflux.
Michelle, can I give you a 5-minute warning here, please? Yeah.
So just in terms of meal composition, obviously one of the big things is with regard to gastric emptying. So you need to make sure that people with Parkinson's are not having meals that are really high in fat and protein, which can slow down digest in the stomach. And the thing about the levodopa is it will basically break down if it's in the stomach for too long, and so it won't get to the intestine. So it slows the medication reaching the intestines where it needs to get into the bloodstream and get to the brain. Obviously, in terms of meal timing has been mentioned, so I think most of you are familiar with this now, so I'll go on through that slide. But this is just typical British and Irish plates of food, which is going to show you, yourselves, those of you who don't have Parkinson's, how long it takes to digest these meals. It has a big impact on medication in Parkinson's. And in terms of protein portion size as well, it's the protein in particular that has the problem in the intestine that competes for absorption of the medication. Protein-rich distribution diets have been shown to be beneficial. I won't go into too much detail in this here, but obviously you need to take into account that it can affect things like malnutrition, bone health, and vitamins and minerals. In terms of the gut microbiome, I'm just going to basically say in summary that more research is needed, but there's some very interesting trials coming out with the likes of Simprove and other probiotics. But eating a diet rich in plant-based foods is associated with healthier gut bacteria and obviously healthier movement of the bowel. I'm very excited in terms of a dietetic colleague in the States is actually running a trial looking at the effect of Mediterranean diet on gastro dysfunction. In terms of it's been touched on, but just again to show you here that basically Helicobacter pylori and SIBO are associated with deficiencies of B12, iron, and vitamin D. And I suppose the reason I mentioned this is vitamin B12 is particularly important because a lot of symptoms of vitamin B12 deficiency mimic Parkinson's. So people might be being put on extra levodopa when actually it's to do with the fact that they're vitamin B12 deficient. That's just a slide there. I'm sure we'll be sharing the slides after, but it shows the different sort of ways that you can look to treat the different issues in the gastrointestinal system. And this is just to focus on, does nutrition intervention work? This was a study. It was done in 60 to 68-year-olds who had, going back to the previous speaker slides, abnormal nutritional status. And there was a 6-week nutrition intervention done with a dietitian and a nutrition nurse. There was ONS used, fiber was increased. They were given, those who were deficient in the various nutrients were given those, vitamin B12, etc., and they were put on a protein redistribution diet. And you'll see here the results were astounding in terms of the benefit to, now it didn't go into specifically the constipation gastro, but I would suspect if we asked the authors, it probably did have an impact. I mean, it's huge. So basically, we really should have, in terms of gastro, nutritional assessment should be a standard approach. We need more research, but really disregarding all of this evidence and us not, dealing with these issues now is negligent as far as I'm concerned. And just to show in terms of the Parkinson's research survey results that we did, again, 8 out of 10 neurologists never asked people about their diets. 9 out of 10 GPs never asked about the diet. 8 out of 10 have never been referred to a dietitian. And only 1 out of 10 of the people with Parkinson's asked to be referred to a dietitian, which I think shows two things. One is the neurologists aren't really looking at diet, and the people with Parkinson's aren't aware that diet can have a huge impact on their symptoms. Just in terms of our previous presenters, their Prime PD, one of their papers showed that 75% of allied health professionals report a lack of PD specific expertise. And people who are experiencing symptoms are not benefiting from the therapies because the AHPs are not being trained enough in it. In terms of resources, they've been mentioned. They're outlined here, so if you can Google them and you can find them easily enough. We have a diet and nutrition guide which focuses in on some of the gastro symptoms on the PEI website you can access. So, sorry, whistle stop tour, and I'll finish there.
Thank you very much. There's so much information to get in here, Rochelle. I think we've probably not got long enough this afternoon to deal with it comprehensively, but there's some great points there. And we'll quickly pass over to Lynn Osborne. I see we're getting a lot of questions in, but we'll quickly pass over to Lynn and hopefully have a little bit more time to explore those. Lynn, over to you now.
Thank you very much Michelle. Thank you, and thank you to the Neurology Academy for asking me to say a few words today. I guess I'm looking at Parkinson's and the gut kind of like from a nurse perspective. And I guess really myself, my colleagues, nurse specialist colleagues, and our medical colleagues and other members of the team, we spend a large amount of time looking at the Parkinson's medication, for which that's just one page of medication. There is a flip side to that, and more medication which is now available. So we spend a lot of time looking at the medication, because we know medication regimes are individual, they're complicated. But I guess added to that, we know that sometimes people forget to take their medication, they don't take it on time, they have difficulty swallowing, as the previous presenters have already mentioned. People also have the absorption problems, as well as a poor fluid intake, poor fiber intake. And I guess really the point of saying this is that all this can lead to constipation, and therefore worsening of PD symptoms. So in terms of constipation, which is really one of the non-motor symptoms of Parkinson's, and I've just really picked the constipation element out from the autonomic part of the non-motor symptom questionnaire, which is widely available, but you know, highlights constipation of being really quite a major problem, and one of which, particularly as nurses, we spend a long time asking people about and trying to resolve the issue for patients. And of course, really, constipation, as well as infections, UTIs and so forth, but constipation back in 2013 was one of the top reasons, the #1 reason for acute deterioration in Parkinson's symptoms, which of course then can sometimes mean unnecessary admissions to hospital. So next slide, please. So putting all this together a little bit, and I guess my main brief was just to give a case study, for which this is Brian, and Brian is 77 years old. He lives at home with his wife. Parkinson's was diagnosed in 2014, and he was referred to me for more of a non-oral therapy opinion, or a device-assisted therapy opinion, in March of this year. And this is kind of like one of the main parts of my role in Cornwall. This man really had a history of unpredictable fluctuations, very severe off periods when his medication didn't work. And in his words, he described himself as feeling locked in. He was often unable to speak when his medication didn't work. And his wife really was having to assist him with most activities of daily living for him. Really, once then I met him. This was during COVID, and during a video assessment. You know, it was quite apparent through asking him a few more questions that he didn't usually take his medication on time. He usually took the medication with food, and therefore it was taking much longer to absorb. He also reported having quite severe constipation. His fluid intake was poor. His dietary intake was poor. He took no laxatives. And so therefore, this scenario I don't think is unusual at all. And so really it was thinking about the next steps. At this time, we use the Parkinson's Kinetograph, for which we've been using on and off in Cornwall since 2015. And you'll see a picture of it here, and that is a watch-like device worn by the patient, and for which can monitor their Parkinson's symptoms from a motor perspective. So apologies, this isn't particularly clear, but I guess the point of showing you this graph is that the red lines going down are the times when medication can be programmed for the person, with Parkinson's. This is just a generic kinetograph graph. It's not actually the one of Brian we're describing today, but really just trying to illustrate the point for you. So you can see the red lines going down are when the medication are taken, and the blue line towards the bottom of the top graph is the bradykinesia line. And really, in his graph finding, really that blue line was quite low, and it really dipped down quite considerably before the medication was due, and then quite significantly it took a long time to go back up after the medication was taken as well. So that showed us really that this man had, you know, quite prominent absorption problems, and may be contributing quite significantly to his deteriorating motor function and his poor control of his Parkinson's symptoms. And so really the plan really going on from here was that this man was also under the care of a community matron, and it was decided really that he needed a CT enema at the time. He clearly needed assistance with trying to increase his fluids, and Laxido as a laxative was suggested for him to take regularly every day as well. Commonly, people do often take their medication with their meals or afterwards, and as he wasn't feeling nauseated, it was suggested he took his Madapar at least 30 minutes before eating, and to try and remember it as well. What we also did with this man was that we changed his oral agonist. I think he was taking pramipexole, so we changed it to reticotine in terms of trying to aid his absorption and therefore control his motor symptoms better. We also then, a bit after that, changed his Madapar standard release capsules to a dispersible formulation, so we could try and get his medication into him much quicker to give him better control. And we then repeated the Parkinson's kinetograph 3 months later, which really did show quite an improvement in his Parkinson's control and his quality of life, to the point that where he was reviewed a couple of months ago, you know, he is now able to shave himself. He's able to have a much better quality of life. He feels that his medication is working much better with less fluctuations. And really, I guess summarizing this, that's why we as a team in Cornwall, we send out the non-motor symptom questionnaire to all of our patients prior to their reviews. We also send out the UPDRS part 2 because it picks up the patient's motor symptoms from their perspective, and it helps us really to identify really what's going on more holistically before the review itself, and certainly as a means to recognize for acute deterioration, because of course what we're trying to do in all this is to keep the patient well, and also to reduce the likelihood of a hospital admission. So thank you very much. I hope that just gives you a quick whistle-stop tour of a case study for you. Thank you.
Thanks very much, Lynn. I think we've had some really useful presentations, and clearly not enough time this afternoon to handle everything. Clearly this is just the tip of the iceberg here in terms of nutritional management of patients and gastrointestinal problems. One of the burning questions that seems to be coming out is around laxative use. And I don't know whether our panelists want to unmute themselves and answer this question, but have we got a kind of a regular laxative that you would prescribe for patients? Is there something that you would recommend, or should we be prescribing this on laxatives on a regular basis? Dr. Mondal has said. So have we got any comments on that from our panel? Lynn, should I ask you first as a practical person, as a nurse?
Yeah, I think practically, anecdotally, laxatives are used a lot, and Laxido is used really quite quite commonly, I think, as opposed to the fiber gels and the lactulose, which don't really tend to be very effective. But I think changes in diet and encouraging fluid intake, and then after that use of laxatives such as laxatives really are really useful, if not essential, for people with Parkinson's.
Yeah.
I might come in on that in terms of, I think with the laxatives, it's not to be afraid to use them, but obviously as dietitians, we're not the ones who prescribe them. But, and also it's an individual, because certainly I've heard, people without Parkinson's, but also people with Parkinson's respond differently to different laxatives. So some work for some and others don't work for others. And sometimes certain ones can cause worsening of, bloating and wind. So that's why you kind of need to look at the whole diet, look at their symptoms, look at what their gastrointestinal symptoms are, and that to decide which is the most appropriate one to use.
There are nice guidelines as well for the management of constipation and a stepped approach to managing the problem. So it's good to be aware of those as well. And we had a question about burning mouth syndrome and how this should be managed. Does anybody want to respond here?
So I can take a look at that if you like, Sue. So as I mentioned, it's been reported to be really common in people with Parkinson's, and the pathophysiology of it seems to be quite unclear, although decreased dopamine levels and dopamine dysregulation are hypothesized to play a role. In terms of treating it, I would suggest a review of current medications, medical history, maybe imaging to look at other potential health problems, tests for gastrointestinal esophageal reflux disease. So perhaps just a bit of further investigation to see if there are any other contributors before it's treated.
Okay. Dr. Mondal has put Parkinson's patients are elderly with comorbidities, so difficult to say whether sarcopenia is due to the Parkinson's. I don't know whether you have a comment on that, or Miho has a comment.
No, I absolutely agree with that. It highlights the importance of having appropriate controls in studies looking at the prevalence. So of the studies I tabulated, not all of them had controlled participants, or some had participants who were people's spouses. So when you came to look at the breakdown, the gender balance and everything was all over the place. But it's a very important thing when we are looking at establishing the prevalence of Parkinson's. We also need to have controls without Parkinson's, so we can actually say whether it's higher or lower than that of the general population.
Okay, thank you. There's another question about, do you recommend build-up for patients? Nutritional supplements, build-up drinks or not?
Well, it just depends. Again, you can't sort of give a generic answer for one supplement, because it's going to be individual to the person involved. But definitely oral nutrition supplements are very useful in terms of managing malnutrition. So it depends on the gastro symptoms. In terms of, like, a build-up drink might be made up quite to a large quantity. It might be quite hard for someone to take if they have, say, slow gastric emptying. They might need smaller volumes of fluid. So it just depends on the individual presentation. I don't know if anyone else agrees with that or has anything to add to it.
I think, Rochelle, you've answered that beautifully, but just to add, it highlights the importance of assessment of our patients on an individual basis to take an individualized bespoke approach.
We have another question here. When managing patients who are ill by mouth and on nasogastric feed, do you advise for ongoing feeds to be stopped before administering levodopa? Any thoughts on that?
Sorry. I think this is actually an area that we need to maybe, look to develop some guidelines around, because I think it's not entirely clear. I don't work with patients who have, NG tubes, but I think my understanding is that I don't think they do stop it. I think they continue it on. But obviously there is the impact in terms of the protein interacting with the levodopa. So I don't know, Lynn, do you have any patients that have been N-tube fed?
No, I don't really. But again, I think, you know, as you've said, it comes down to that individual assessment, and, you know, and the, you know, I guess what we're alluding to around this is protein sensitivity, really, which really recalls for certainly more research, but I think it's quite individualized, and there probably isn't a standardized approach.
Okay. There is a quick question here about probiotic drinks. Should we be recommending them? Okay,
I might come in on this one. And I'm sure Fiona and Michael probably have a view after the little review. But at the moment, the evidence is not strong enough to be, you know, suggesting that people take probiotics, because we're not entirely sure in terms of the positive or negative. Certainly some very exciting research around the likes of Simprove having benefit on sort of bowel movements and potentially having an effect on symptoms, but we haven't enough proof yet in actual Parkinson's people to say that it definitely is something you should go off and you know, take off the shelf. Because one of the things the research shows is that we tend to have high levels of lactobacillus and bifidobacteria when they assess, but we don't know whether that's a good or a bad thing, to be honest, and there aren't enough, you know, studies yet to clarify that. So I, as a dietitian, I would be a little bit nervous yet to say to take any specific probiotic, but I'm hoping that we'll see more research over the next while, because we as patients with Parkinson's are really, people are taking them anyway, and we don't know if they're having a negative. So we need clarification on this. So I'm sure Michael is nodding there. He probably has a view maybe, or Fiona on that.
Yeah, I think we're in total agreement with you. It's really the cutting edge of research at the moment, but I think we just need an evidence base to gather, don't we? So people can decide what the best approach is and which the best strains are.
Yeah, thank you. I'll just make one comment, because we've had a lot of comments from geriatricians here to point out that they do holistic assessments and do weigh patients and do check their bowels. So we've noted this from our many geriatricians that have commented, and we do know that you do that. I think it's been a fascinating afternoon. We really need to close now. So I'd like to thank our speakers, Fiona, Miho, Michelle and Lynn, for their presentations. I think we could probably run a webinar like this again. There's been so much to get through. We clearly need some guidelines around managing patients better, particularly around constipation and diet. So who knows, we might be able to run another webinar sometime to continue to explore this underrepresented issue. We'll close now. I think you'll be emailed out an evaluation form so that you can complete that and let us know how you felt that the webinar went. But thank you very much to everybody, to our audience and to our speakers this afternoon. I think it's been a tremendous session. Thank you. Thank you. Lastly, as well, thank you to Kiowa Kirin for their support in terms of running the meeting. We'll see you all again soon.
Thanks very much, Sue.
Bye-bye.